My name is Kevin Tay, and I did the case study presentation on Isabel Ringer, who reported numbness in the left hand. Hello everyone. Today I'll be discussing the case of Isabel Ringer, a research assistant who has recently experienced numbness in the third, fourth, and fifth fingers of her left hand. Isabel's job involves constant, detailed hand movements, such as typing, grasping instruments, and performing repetitive wrist and finger movements. Because of the discomfort and loss of sensation, she's been using her other hand more often to complete her task. Based on her symptoms and occupational demands, 3 possible conditions are being considered. Ulnar nerve compression, carpal tunnel syndrome, and cervical radiculopathy. The most likely condition is ulnar nerve compression, commonly known as cubital tunnel syndrome. This happens when repetitive elbow flexion or prolonged pressure on the cubital tunnel compresses the ulnar nerve, which controls sensation and some muscle movement in the ring and little fingers. Over time, this compression leads to tingling, numbness, and weakness in the affected hand. As a nurse, independent assessments can include performing Tinel-Sign at the elbow by gently tapping over the cubital tunnel to reproduce tingling, testing grip strength by comparing both hands, and inspecting for muscle wasting in the hypothenar region. These assessments are indicated when the patient reports numbness in the fourth and fifth fingers. Normal findings would show no tingling or weakness, while normal results include tingling in those fingers, a weaker grip, or visible hand muscle wasting. The second possible condition is carpal tunnel syndrome, which results from the compression of the median nerve at the wrist. Repetitive wrist movements such as typing or fine instrument handling can lead to swelling and nerve entrapment. Though carpal tunnel syndrome typically affects the thumb, index, and middle fingers, overlapping symptoms can sometimes extend to adjacent digits. Nursing assessments that can be performed independently include Phelan's test, where the patient flexes both wrists and holds the position for 60 seconds to see if tingling occurs. Another test is Tinel-Sign at the wrist, which involves tapping over the carpal tunnel and evaluating fine motor tasks like buttoning or grasping small objects. These tests are indicated when numbness worsens with wrist use. Normal findings would include no tingling or burning sensations, while abnormal results show numbness, tingling, or decreased dexterity. The third and least likely condition is cervical radiculopathy, specifically involving the C8 to T1 nerve roots. This condition occurs when a herniated cervical disc or degenerative spinal changes compress the nerves that travel from the neck down to the hand. Patients often report neck pain with radiating numbness, tingling, or weakness along the arm and into the fingers. Independent nursing assessments include checking the neck's range of motion, performing Sperling's maneuver by gently extending and rotating the neck while applying light pressure, and conducting a sensory assessment on the forearm and hand. These assessments are indicated when upper limb numbness occurs with neck pain or stiffness. Normal findings would include full neck mobility and intact sensation, while abnormal findings may include pain radiating down the arm, decreased sensation, or weakness. In summary, the evidence suggests that Isabel's numbness is most consistent with ulnar nerve compression, followed by carpal tunnel syndrome, and finally cervical radiculopathy. As a less likely cause, all 3 conditions are linked by repetitive hand use and nerve compression, which disrupt normal sensory transmission. The nurse's role involves identifying the affected nerve pathways through focused, independent assessments and recognizing when further medical evaluation is needed. By using these targeted nursing assessments, we can help determine the most likely diagnosis and support the patient in preventing further nerve injury.